speaker this month. Very excited.
Absolutely. Thanks, Amber. Hello, everyone. Welcome. This is our education series that we host monthly with Parkinson's Nebraska, and Amber and myself for PDWell kind of co-host an effort at promoting education across the Parkinson's community here in Nebraska. And we're very privileged today that we have Dr. Bhatti with us from Nebraska Medicine. He's a movement disorder specialist and is going to talk to us today on updates in research. So we really appreciate you coming. We know you're very busy. I know you also have something to be at right at 3. So we're going to wrap up about 2:55. So don't wait for your questions at the end. Put them into the chat and we'll try to get them over to Dr. Bhatti as we go so that we can wrap up and get him on to his next obligation here later today, or opportunity, right? His next opportunity of the day. So I will turn it over to him. Thank you so much for joining us.
No, she went. Can't hear her.
I can't hear you, Dr. Bhatti, but you're not on mute.
Where is she?
Let's read.
All right, how about now?
Yes, thank you. Yes.
So I'm on call for hospital this week, so I might have to take a break if I get a page and they have a transfer or something coming in. So I apologize for that. I might have to take a few minutes break in between. But let me share my screen and start some review of the topic. You can stop me anytime you want and ask me questions. So I thought I will review this topic that I also just reviewed in Columbus about updates in Parkinson's disease in 2020. And just give you an idea or sketch of what I am seeing in terms of research or new breakthroughs. None of this is approved therapy. So anything that I discussed today is investigational and experimental. I will breeze through some of the topics and so that I can give you time to ask me questions more specifically. I would like to dedicate the talk to the memory of my father who wanted me to do more education. I do have a lot of financial relationships, speaking, consulting, advising, research funding with various companies that make drugs for Parkinson's, but I'm not talking about anything that's out in the market today for Parkinson's, so no disclosures. So I will give you some updates on research from 2020 and focus on a couple of areas such as immune therapy, neurotrophic therapies, and innovation.
I can understand when you talk too fast.
Questions?
He's got an accent.
So in 2020, if we look at the trials that are going on right now, there is this nice summary slides that tells you what trials are actively going on. And if you look at all of these collections of the drugs or trials that are going on, the top half are for the medications that is for disease modification to slow down Parkinson's, while the bottom one is for what we call symptomatic therapy, where we are just making symptoms better. And in the top half, there are 53 studies or 57 trials that are going on in 2020 to slow down Parkinson's. But there are different stages. These are all human trials, so these are not animal studies. These are studies that are already going on in human, but they are at different stages. So phase 1 will be where they are trying to make sure that there is no concerns for safety. Phase 2 will be where they're trying to establish what's the right dose of medication. And phase 3 is where they confirm that it actually works. So you'll see that most of these trials are in phase 1 and phase 2 study, where they are still establishing safety and dose and not necessarily establishing effectiveness. And only 3 were phase 3 trials in 2020 last year. This is the magnification of that picture, and you see a lot of different colors there. And these colors are difference in mechanisms on how these drugs work. So blue, for example, is the immune therapy. So they are trying to modify the immune system. Another example will be, so this is what I'm going to focus today in the next few slides. There is also what is called neurotrophic. So that's a mechanism where we try to make cells grow and become better and healthier and stronger. And that's also what I'll touch upon today. But there are many other therapies that I will not have time to go into details. For example, there is botanicals, there is the microbiome or the bacteria in the gut. There is what we call the cell therapy, where, for example, stem cells, and antioxidants, and so on and so forth. So as you can see, there's not just one way of trying to slow down Parkinson's. There are dozens of different ways, and there are drugs in all of these categories that are being studied for slowing down Parkinson's. So let's look at one of this category, immune therapy. And this will be where we use the immune system and to make Parkinson's better or slow down Parkinson. And in order for me to explain how immune therapies are working, I wanted to show you what are we targeting. So in Parkinson's brain, the change that happened is growth of accumulation of these proteins called alpha-synuclein protein. And the accumulation is called Lewy Body. It starts at the bottom of the brain. That's where you get problems like sleep problems, constipation, loss of sense of smell. And then gradually it spreads up to the middle of the brain, where you get problems like tremors and slow walking. That's where we diagnose Parkinson. And in some people, it can spread eventually all the way to the top of the brain, where we get problems like dementia and balance problem and freezing. This is a slow, gradual process. It takes 2-3 decades for this to complete or longer. But this is what we're trying to stop with immune therapy and other treatments. What those Lewy bodies look like in a brain cell. So this is a brain cell, and this is a Parkinson cell. This is the cell that makes dopamine. And this is a normal, healthy cell. It has these melanin that gives it black color. And in one of these cells, you can see this pink accumulation, this kind of a globule or a drop, and that's abnormal. So a healthy cell will not have something like that. And that is called Lewy Body, and that is made of these protein which has accumulated like a junk, which is called alpha-synuclein. So this is a normal, healthy alpha-synuclein, and this is a bad one that should be removed. And when it cannot be removed and accumulates, you can see something like this alpha-synuclein. One of the recent findings last year was that when that cell dies, which is sick, pieces of that Lewy body or alpha-synuclein protein are released into the brain, and they go into the spinal fluid. And these pieces or fragments of Lewy bodies can attach to lipid proteins or lipid drops in the spinal fluid. All of this is very, very microscopic. So this is an electron microscope, not a regular microscope. This is a lipid drop in the spinal fluid, which is naturally present. It is naturally taken up by other neurons. So it's kind of a mechanism of transport. But this here is one of those fragments of alpha-synuclein or Lewy body, which is present on the lipid drop in the spinal fluid. So if you take spinal fluid out of the bag and test it in a Parkinson's patient, you can pick up these fragments. And that's one of the ways we're trying to make up a test for confirmation of Parkinson's. But these fragments are so small that to test them reliably is very hard. And that's why that test is still under development for the last 3 or 4 years. So we have known this for a few years, but we have not been able to produce a commercial test to look for these and confirm the diagnosis of Parkinson. But one of the problems is that these lipid drops are taken up by healthy neurons. This yellow neuron is a healthy neuron. It's gonna naturally take up these lipid drops to recycle the lipids. But now some of the lipid droplets have these fragments on them. And that way, a dying neuron can transfer and speed up the process of Lewy body in a healthy neuron by giving up these fragments. So one of the approach with immune therapy is to see if we can block these alpha-synuclein proteins in the body and clean them out. So one way to do that will be by giving something that binds to these, what we call an antibody. So this is a trial that was published 2 years ago and reanalyzed last year. It's called Pasadena study, was done in UK, where they gave patients with Parkinson's disease these antibodies. I think there were 12 or 16 patients who were given these antibodies, which were supposed to bind with the alpha-synuclein and remove it from the body. When they initially published the data 2 years ago, and they looked at patients who were given low dose and high dose of these antibodies, and they looked at overall score of improvement, they found no benefit. So 2 years ago, they came back and they said, these antibodies are not working or not giving any benefit to Parkinson's patient. However, last year, they went back and they looked at only the motor score, the score that we do in the clinic, when we have you do finger tapping and hand open and close and different things. And when they looked at that part of the score, they found a clear benefit to patients who were getting antibodies. Their score went down and their Parkinson's did not progress as much as those who were getting placebo or plain water. And now, based on that, they want to proceed and do a larger trial in a phase 2 and 3 trials to see if that actually works. They looked at many other outcomes. They looked at time it takes to start therapy, for example, Parkinson's therapy, and they showed that whoever got those antibodies, they could wait longer and not start medication right away. And that was another benefit. That is not the only company that is making the antibodies. There is another company that is doing a trial right now called Spark trial. And they're also doing the same thing. They have their own antibody, which they have a chemical name for, which they're giving at 3 different doses, very low, medium, and high dose, to see if that will slow down the progression of Parkinson's by giving antibody infusion. These are typically given IV once a month, and these studies are typically 1 to 2 years long. So this trial is 2 years long. So once a month infusion for 24 months. And they have 18 Parkinson's patients and also some healthy people, just to make sure that there is no reaction to it. Now, another way to produce antibodies in the body is to not give the antibodies, but force the body to make antibodies. And that's called a vaccine, just like the COVID vaccine. So what COVID vaccine did was that it took a fragment of the virus and gave it as an injection in a way that created a response, an immune response, and body started making antibodies against the virus. Same thing is being done in Parkinson's. So there is a trial called AFRES Trial, which has been going on for 4 years, 3 or 4 years, where they are giving fragments of that alpha-synuclein, which you want antibodies against, directly to the body to see if you give it as an injection to the blood, if body will start making antibodies. So they gave 2 doses, they followed for 1 year. They saw that the body of those patients was making antibodies. And after a year, the level started dropping low, and they gave a booster dose, and they keep following them. And then after a year, they gave a 3rd booster. And they have shown that if you give a booster once a year for a couple of years, then you can have antibody response to these vaccine or proteins. So you don't have to give infusion of antibodies. And although they were looking at just safety, but when they look at those patients who have been getting these vaccines for 3 years, they found those patients who have gotten high doses throughout the 3 years have less progression of Parkinson's when measured by the examination, the UPDRS, as compared to those who were getting low dose. So everybody was getting a vaccine. They did not have any placebo in this because this is a safety study. And those with high dose of vaccine had less progression over the 3 years as compared to the low dose. And even in the low dose, the progression seems to me as a low progression over time and not a high progression. So that is showing that maybe we can give vaccines to make Parkinson's patient more resistant to the progression of Parkinson's. Then there is another mechanism where you can do immune therapy, is to take the immune antibodies from healthy people. So what will be an infusion of plasma or blood infusion? So that's another idea that is being looked at, that what if we take people, healthy people, and take plasma donation from them and give it infusion to Parkinson's patient, will that slow down their Parkinson's? So this was again a safety study done last year in 15 people with Parkinson's. They were given twice a week an infusion of plasma for young healthy donors, and they were given twice a week for 4 weeks, so 8 doses. And then they were followed for another 4 weeks, 8 weeks, to look at if it's safe for them, and it was safe. And they also looked if there is any response coming out of it, and they did find a benefit of giving plasma infusion. So that seems to be another possibility of how you can do immune therapy for Parkinson. And this is not unique for Parkinson. The same idea have also been tried in Alzheimer's, and there have been studies looking at donation of plasma to slow down the progression of Alzheimer's with the same idea. So those were some of the examples of the immune therapy studies that are going on to try to slow down Parkinson's. Another mechanism that I mentioned that I wanted to highlight is what is called neurotrophic mechanism, where we are supporting the cells, different things in the cells, so that they don't die early, so they can stay alive longer and they can stay healthy. So let's look at some of these studies that came out last year that seemed very exciting to me. So this study looked at the dopamine cells in animals, and they found that there are certain dopamine cells that get turned off in Parkinson, and then you can turn them back on by giving them a signal. So in the mouse, they were using the light as a signal. So these mouse, they develop Parkinson's when you turn off those cells, and then when you turn them back on through the light signal, then they become normal and they become healthy. And why this study was being done, or why this is useful, is because we already know from autopsy studies that people, when they die with Parkinson's, they still have some dopamine cells that are there, that they're alive, but they were not working. So they were just turned off, they were shut down. So far we have only thought that Parkinson's disease happened because of death of brain cells, death of dopamine cells. But now we're seeing this data that Parkinson's can happen, or patients with Parkinson's have dopamine cells and they're just turned off, they're shut down and they're not working. And the question will be, can we turn them back on? Can we start activating them so that they can start making dopamine again? And that's one thing that is being looked at. So this study that was published 2 years ago looked at the brain of people with Parkinson's, and they found that there were cells that could still make dopamine, but they were not making dopamine at the time of death. So there are studies in Alzheimer's looking at use of light therapy to see if we can improve Alzheimer's. I don't think we need to do light therapy in Parkinson's, but there are drugs that might be able to turn those off cells back on. And for example, these drugs like Rezagiline or Azilect that we have used, they have the potential to turn these cells back on. And we have actually studied drug like Rezagiline or Azilect in the past to see if that will slow down Parkinson. And there were this trial done 10, 15 years ago, looking at slowing down Parkinson's disease in early Parkinson with Rezagiline. At that time, we did not know how it will work. And the trial didn't succeed, but we stopped doing the research because we weren't sure how this drug works. But now we're starting to see some mechanism on how that drug might actually work. Another thing that we can do to support these cells from not dying is coming back to this topic that I mentioned before, that there are these fragments of alpha-synuclein that are binding to the lipid droplets that are being taken up by the healthy neuron, and a transfer happening. Now, one of the other finding is that the alpha-synuclein, the Parkinson protein, does not bind to all the lipid droplets. It only binds to some of them. And it binds to those lipid droplets which also have an ApoE protein. ApoE protein is already known to us from the research in Alzheimer's. ApoE protein has a function where it can increase the risk of Alzheimer's. So ApoE protein actually comes in different flavors, E2, E3, E4. the E4 protein increases the risk of Alzheimer's and E2 protein reduces the risk of Alzheimer's. But now we think that the ApoE also has a role in Parkinson's. And this study done last year showed that if you take mice with and cause them to have Parkinson, if you have ApoE2, then you can actually protect them from Parkinson's or have less Parkinson. And if they have ApoE4, then they have a high risk of Parkinson's and increased progression of Parkinson. So this is just an animal data right now, but that shows promise that the studies we're doing for Alzheimer's for ApoE might also be useful for Parkinson's patient, where not only we slow down Alzheimer's, we can also slow down Parkinson's by using similar kind of mechanism of ApoE. Another studies that were done in the last couple of years, published last year, have been looking at different chemicals that make the cell more healthy and stronger and grow more branches. These factors or these proteins are called NF, which stands for neurotrophic factor. So these are the factors that are required for growth of the nerve cells or healthier growth of cells. And there are many different types. So for example, one type here is CDNF. And there was a study published last year that looked at using concentrate of CDNF, this growth factor, infused into the brain to see if we can slow down Parkinson's by giving the infusion in the brain. So it will be once a 6 months or once every 3 months infusion that is done through this infusion port, and that will slow down the death of these cells. That's not the only factor that is being looked at. 2 years ago, there was a study published that looked at another factor, which is called GDNF, using the same process, where an infusion into the brain was given of this neurotrophic factor to see if that will slow down Parkinson. And then there are even more factors. The names become very complicated, but all of these factors are trying to slow down the Parkinson's by increasing the growth of nerve cell. So here's few more names, but I don't want you to get confused with the names, but they are all using the same mechanism. But this study was even more advanced study that was published last year, where they took these nerve factors. So in the previous study, they were infusing those factors concentrated in outside. So they were produced in a factory, and then they were given as an infusion. But in this study, what they did was that they infused the gene of that nerve factor into the brain and made the brain start producing those factors locally. So rather than producing the factors in the lab, they want the brain to have the capacity to make those factors themselves. So the way to induce the brain cells to do it is by sending the genes packaged in viruses. So they take viruses, they put genes in those viruses for those factors, and they inject those genes in the brain, and then those viruses then cause a local infection, the stained area here, and that infection is basically making these brain cells have those extra genes so that they can start making the factors themselves. So now you have lifelong production of those additional factors without the need for infusions in the brain. And this is a brain from a patient who was injected with those viruses 8 to 10 years before they died. So 10 years ago, someone was given an injection of these viruses, and 10 years later when they died, when they looked at the brain was still making those factors. They were still producing all those healthy factors that will make their brain last longer. So that's another mechanisms that we are looking at to make Parkinson's brain stay healthy. And another one, which is now starting to become very complex, is what we call mitochondria. Mitochondria is part of these brain cells, nerve cells, and they move around in the brain. And their movement is necessary for the nerve cell to remain healthy. And one of the problems in Parkinson that we have seen through various mechanisms, including genetic Parkinson, is that these mitochondria, they become too sticky and they stop moving. When they stop moving, they just stay in one area, and that becomes unhealthy for the brain cell. And that brain cell cannot clean out that alpha-synuclein that was being accumulated, the bad one, and that makes it form the Lewy bodies and die. And what we're looking at is that can we give drugs to these patients with Parkinson so that the mitochondria does not become sticky and can move around and get better. So there are various ways that we can induce these mitochondria to become more active, move around. And these are complex mechanisms, but the idea would be that these mitochondria will do a better job in cleaning out that alpha-synuclein. And then lastly, I want to point out another of this study that is looking at stem cells. So stem cell is a cell that can become any other cell that you want it to become. So this paper published last year was on a single person, a single patient from New York. Few years ago, that patient enrolled in this project. The scientist took some of his skin cells. These skin cells were then converted back into stem cells. These stem cells now become any cell, but usually they want to become the skin cell again. These stem cells were then changed into the cells that should become nerve cells or dopamine cells through multiple steps process. And then after checking multiple batches and finally selecting the batch that for sure will make the dopamine cells, this patient in 2019 was given back the injection in his brain of his own cells, stem cells. So his skin cells were converted to stem cells, converted into the stem cells that will make dopamine, and they were injected back into his brain. And this paper was published 6 months after as an update or report on that person, that one person who had this process done. And they showed that the patient is doing fine. There is a slight improvement in his Parkinson, but there have been no side effects from the stem cells injected into his brain that was taken from his own body or prepared from his own body. Another thing that is going on in Japan is that what the people in Japan are saying that it is too hard to make stem cells for each person individually. So what they are proposing is that we should have a bank, a biobank of stem cells from donors. So they take people, invite people to donate their cells like blood cells or skin cells. They convert them into stem cells and grow them in lab and create a large bank of a lot of donated stem cells. And now those stem cells can be injected to anyone with Parkinson's after matching, just like you match for other transplant, you match for kidney transplant, bone marrow transplant, other plant transplant. You do same kind of matching for these stem cells, and then you inject them into the brain, just like you do the DBS, into the deep part of the brain. And these stem cells that are donated from a donor, not the person's own stem cell, will now go on and become dopamine cells. So they have been collecting all these stem cells for last 5-10 years in Japan. And last year they enrolled 7 people in the Kyoto University Hospital. And these 7 Parkinson's patients were given injections in their brain of the stem cells from donors. So that was not their own stem cell, but the stem cell from other people in Japan who donated, who were matched just like you will do for any transplant. And now those patients are being followed. We don't have any update yet on how they're doing with these donor stem cells that were given injected into their brain, but that's something that we'll be looking for in 2021. There were some breakthrough in science that happened last year that will make it much easier for us to do these studies. And I wanted to show you some of those breakthrough. So one of this breakthrough, for example, that I wanted to highlight was a better way to study the brain. And that better way was to be able to look through the brain as a transparent brain so that you can look at all these brain cells. So this is a small part. This is a 1 millimeter size portion of the brain, less than a quarter of a rice grain that is being enlarged. And you can see all these cells, brain cells, and their connections in the brain easily now by making the brain transparent. So how does it work? They take the brain tissue and they dissolve everything except the neurons out of that brain and leave a water kind of a gel that you would use to hold those nerve cells in place so that they don't move. Once you have done it very nicely, there are 2 brains in this picture. This is a normal mouse brain, animal brain, and this is a brain that has been made transparent. So all the neurons or brain cells are still there, but now everything else is gone. So you can see through the brain, transparent. This technique is called clarity, and it's also now available at UNMC. And now you can stain the neurons with different colors to start seeing them. And now you can tell what different cells are doing, which ones are dopamine cells, which one are a different type of cells, who is connected to whom, and that way you can tell very easily how different connections are disrupted or are abnormal in someone with Parkinson's disease. And so that will be a big breakthrough in research for Parkinson's and other brain disorders. Another breakthrough that I wanted to highlight was this computer that can now calculate what the protein in the brain should look like. So normally protein are folded into these complex structure which have a very unique shape. And this shape has to be precisely exactly the same for the protein to work. So if you are designing a therapy, an immune therapy or a drug that is based on protein, you have to match the shape. But to match the shape, you need to know the shape precisely. And previously, we would study these shapes piece by piece, one small piece at a time to come up with an overall shape. And it will take us 2 to 3 years to come up with a shape of a single protein. And there are more than 10,000 proteins in the body, in the brain alone, that we need to know to be able to do these studies. And what happened last year was that they finally made an artificial intelligence computer, an AI, by Google. It was called Google's DeepMind. And they created a software on it, which was called AlphaFold. And they trained the software to predict what these protein shapes to look like. And they had a competition to see if someone can do this with 90% accuracy, that more than 90% accuracy of what the shape of protein should look like. Now, this used to take 2 to 3 years for scientists to do it in a lab. And the computer was able to do it in 1 hour. In less than 1 hour, Google's DeepMind was able to use the software to predict with more than 90% accuracy what the shape should look like. So the 2 years research is now being compressed into 2 hours of research by using artificial intelligence and these smart computers. And that will save us so much time, and hundreds of years of research will be saved by using software like these and programs like these. So all of these innovations are extremely exciting and gives me big hope on how we can solve the puzzle of research in Parkinson's. This is very complicated subject, so I went through it a little briefly so that we have enough time so I can see what more you would like to know, what specifically you would like to know. So I will pause here and let you ask specific questions about what I discuss or anything else in the research that you're interested about in Parkinson's disease.
What studies are you working on now at the university?
So last year we didn't do any study because all the research was shut down and closed because of COVID. We have just restarted our trials in March. We are so we have been accepted as a part of the study for antibodies for Parkinson's disease, the Pasadena study that I showed earlier. So they want to do a phase 2 with 20 different universities. So we have been selected as one of the university. So we will be looking at patients and giving them infusion, once a month infusion of the antibodies to see if we can slow down their Parkinson. So that's one of the study that we'll be part of. We were offered to be part of the brain infusion study where they were giving neurotrophic factors into the brain. So you need a port implanted with 6 tubes going into your brain and an infusion given once every 2-3 months. That was too complicated a study, so we decided to pull back and not be part of that one. But that study seems to be starting, so there will be a phase 2 study on that one too. Another study we're doing in UNMC is on deep brain stimulation, DBS. So when we do the DBS surgery, we put the wires in the brain, we hook it up with a battery, and we do the stimulation of the brain to improve Parkinson's symptoms. So there is a new DBS device that is now available on the market. It's called Percept device. That device has the ability to also sense the electrical activity of the brain. So not only it can give stimulation to the brain, it can also detect the natural stimulation of the brain. So we just got approved for a study where we will be looking at that stimulation from the brain of Parkinson's patient and design unique stimulation patterns for those patients. So we'll use their own brain information to change the stimulation for their brain to see if we can make their Parkinson's even better with this newer technique. We'll also be using that device to look at the brain patterns overnight in their sleep. So Parkinson's patient will have the wires put in, and typically we wait for a week before we put the battery in. So while waiting for the battery for the week, we will have them come into the hospital for 2 nights, stay at the hospital, and we'll hook up those wires with our computer, and we will study their brain stimulation pattern overnight during sleep and see what happens to Parkinson's signal in the brain or brain signal in Parkinson's patient overnight and why it disrupts the sleep, and see if we can find ways to improve the sleep in Parkinson's patient that way. Another study that we are doing in partnership with UNO will be to see how can we improve freezing of gait. So Parkinson's patients sometimes when they're walking, they get frozen for a few seconds, their feet doesn't want to move, it gets stuck to the ground and then it gets going again. So we want to see if we can improve that freezing of gait by certain techniques, such as special kind of devices, such as use of music, other physical therapy techniques. And we want to, so that UNO has a large grant, a 3-year grant to study the freezing of gait in Parkinson's patient. So that will be another one that we'll be partnering on. Those are the ones that are going on. Oh, one more that will be going on this year that we did continue last year a little bit is to look at nutrition in Parkinson's patient. We want to see that what is the effect of different diet on people with Parkinson's disease. So we've been doing diet surveys. We have been checking their vitamin levels, and we're doing examination of these Parkinson's patients, and we want to see that what's the interaction of all these things. How does diet affect Parkinson's? How does diet affect progression of Parkinson's? How does diet affect vitamin levels? And so on and so forth. So we have now data on 180 patients that we collected over the last 2 years. We are presenting that information. We just presented at American Academy of Neurology meeting, and we'll be presenting it in World Congress of Neurology meeting, and we'll be writing some papers on the effect of diet and nutrition on Parkinson's. So these are the ongoing studies, and then there are 3 or 4 studies that we're still in the stage of planning and writing up application for approval.
What are the clinical indications for DBS just in a standard patient today, non-research?
So standard indication for DBS is to improve the fluctuation during the day. So initially with Parkinson's in the first few years, first 5 years or so, when you take medication, you have a good response throughout the day and you don't have any loss of response. But over time, after 5 or 7 years of disease in Parkinson's patient, the medication kicks in, but only for a few hours, and then the benefits are gone. And then you have to take medication again, and then you get the benefit again, but it creates too much fluctuations throughout the day. And then over time, as you increase the medication amount, you start getting side effects from the medication, and there's a limit on how much you can take. So those patients are the ones that are candidate for the deep brain stimulation. And once they get the DBS surgery, the day becomes smooth and the medications come down. So they need less medication, and they have control of symptoms throughout 24 hours without any fluctuations up or down. And that's the main use of deep brain stimulation.
How do you decide which patients are appropriate for DBS?
So we need to look at 2 things to decide if the patient is appropriate for DBS. Number one, how likely it is that they will have benefit. Not everyone get benefit from DBS. Some patients do, and we have certain ways to pick those patients. So we want to make sure that we think the patient has a high likelihood of getting benefit. So that's the one question we have to answer. And there are a few steps we do to try to answer that question. And then the second question in the patient is to make sure that they don't have a high risk of side effects. So everybody has some risk of side effects or complication, but usually in a good selected patient, the risk is 2 to 3%, so not very high. But there are some patients which will have a much higher risk of side effect, maybe 30% or 50%. So we do we do some evaluations to answer this question that we think the patient does not have high risk of side effects. So if we find a patient who has high likelihood of benefit and very low likelihood of side effects, those are the patients who are considered good candidates for DBS.
Sometimes during the day, this isn't every day, but today is one day, I get extremely spacey in my head, and I have a hard time concentrating or thinking of, if I'm trying to think of a word or whatever, I'm having a hard time with that. And then it just goes away. What causes that?
Yeah, so there are two common reasons that I can think of, and there are probably many more possibilities. But one of the common reason is low blood pressures. People who have drop in their blood pressure from Parkinson, it affects their brain and they get a mental fog or confusion, and it may not be an obvious lightheadedness. Sometimes it is obvious lightheadedness, but sometimes it's not. And if you check the blood pressures and you find them low, and the only symptom is a mental fog or confusion, and that's transient, it comes and goes. The other reason is Parkinson's itself. When the dopamine runs low in the brain slows down. Dopamine is necessary for processing of information. So you cannot think fast enough without dopamine. So that's another reason that some people who have fluctuation, where the dopamine levels go up and down with medication, as we were discussing in DBS, then as their level drop, their brain slows down. It takes harder for them to process the information, and their thinking is slower, and they have a mental fog. And once the dopamine level comes up with the next dose of medication, then that clears up and they feel better and they can think more sharper. Those two are common reasons, but there are many things that can affect thinking. Lack of sleep, sleep apnea, people can have seizures that can affect the brain and thinking, and so on and so forth. There's a long list of possibilities, including medication, but the two common ones are the one that I mentioned. So there are two questions in the chat box that I find out. I can address them. First one is a question about Verdiperstat from Biohaven for MSA. I am not familiar with this drug. I have not read any information on it. MSA is considered part of Parkinsonism, but within Parkinsonism, then there is Parkinson's disease, and then there is MSA, and there is other diseases. My research is focused on Parkinson's disease. Dr. Sayer has interest in doing research on Parkinsonism, other Parkinsonism like MSA and PSP and CBGD. So any trials or research that come related to that, I typically refer it to Dr. Sayer, Dr. Hellman, Dr. Situ, and those people have more interest in atypical Parkinsonism. My research focuses on idiopathic Parkinson's disease, so I'm not familiar with literature outside of that, so I'm not familiar with this drug. And one other question I see here in the chat box is about being concerned about carrier. So someone is saying that they have someone with Parkinson's in their family, and they want to be tested to find out if they are a carrier or not. Genetic Parkinson's disease is very uncommon. Less than 5% of Parkinson's disease is genetic Parkinson's disease.
Okay.
And those Parkinson's disease are seen in people before age 40. So if someone has Parkinson at age 31, 32, 37, 29, those are the people I will be worried about genetic Parkinson's disease. If someone has Parkinson's in their 50s, 60s, 70s, 80s, I am not concerned about genetic Parkinson's disease. And I don't, we don't have to worry about carrier status. But if someone has someone in their family, like someone's parent had Parkinson's disease before age 40, then they should have a concern about genetic Parkinson's in career status and things like that. Now, there is one other concept to be clear of that sometimes confuses people. We do genetic testing in people in 60s and 70s and 80s. There are 2 genetic trials going on right now that I would tell you about in a minute. But we are doing genetic testing not for genetic Parkinson, but for genes that will make it higher risk of Parkinson's or faster progression of Parkinson. So there are some genes that make it so that you have a higher chance of Parkinson's. So normal chance of Parkinson is 4%. Everybody before they die, they have a 4% chance of getting Parkinson, 1 in 25. Now that risk can go up to 6% or 8% or 10% with some genes. Now that does not mean genetic Parkinson's because it's not 100%, right? Even if it's 10% chance of Parkinson, 90% means you're not going to have Parkinson. But those genes make it slightly more likely for you to have Parkinson's. And those are high risk genes. And those are the ones that we think about in someone who have Parkinson's after age 40. And some of those genes can actually make your Parkinson's progress faster than others. We think that those genes are present in 30% of people with Parkinson's disease. 70% don't even have those. So 70% have no genes increasing the risk whatsoever. But 30% of people, or 1 in 3, may have a gene that makes it more likely for them and maybe their family members to catch Parkinson's, slightly more, maybe 6-8% or 10% kind of. The data is not clear on that, but slightly more. Those are the genes that are being studied right now in 2 trials, in 2 studies. There is one study by Michael J. Fox Foundation that is called Fox Insight. It's a free study. You can go to their website and enroll in it. They will send you a swab, a cotton swab on a stick at home. You will rub it in your mouth. Some of your mouth cells will get attached to the cotton. You will send them back, ship them back. They will grow your DNA from those mouth cells, and they will look for those. I believe they're looking for 3 genes that are increasing risk of Parkinson's in some families slightly. And they will send you a report back, and they will save some for their future research. The other study that just started is called PD Generation. PD Generation is a study by Parkinsons Study Group, the group that I belong to that does Parkinson's research. We're doing the same thing, but we are looking at 9 genes, not 3, much bigger portfolio. It's being done by Parkinson's Study Group under research grant. However, this is not direct to PD Generation. It has to be through your physician. So it has to be through me or Dr. Syed or Dr. Torres, Dr. Situ, Dr. Hellman. You have to tell them that you want to participate in that study. We have to send a referral to PD Generation, and we will get a copy of the report because it's more bigger report. It's 9 genes. And it may be that once you get the report, you will not know what it means. It might be confusing. And the idea is that if we get a copy of the report, then you can call us or you can come and see us, and we can walk through the report with you and tell you what the report means. So that's PD Generation. So that's one study. And the other one directly is Michael J. Fox Foundation study called Fox Insight. And you can go to MJF study website and find about Fox Insight and enroll directly. And we don't get any report. We don't get any copy on the Fox Insight. And those are looking for the at-risk genes that don't cause genetic Parkinson, but they just increase the risk of having Parkinson's more than normal, slightly higher.
What is MSA?
MSA is a different disease than Parkinson's disease. It's also has Lewy bodies in the brain, but not the way Parkinson's have it. Parkinson's have the Lewy bodies in dopamine neurons, while in MSA, the Lewy bodies are in supporting structure. They're called astrocytes. So those are cells that we dissolve when we do that clarity technique for the brain, right? So we're removing everything else besides neuron. The MSA can have some symptoms that look like Parkinson. So they can have tremor, they can have slowness like Parkinson, but then they have many other problems unique to them that is not seen in Parkinson. However, early on, it may be very hard to tell them apart. both have problems with Lewy bodies, both have things like tremor, both have things like slowness, both can respond to dopamine. So they look very similar early on, but over time, MSA progresses differently and have a lot more additional symptoms that are not seen in Parkinson's disease. And in the brain, it's a very separate disease. So if you look under the microscope, you can tell this is Parkinson's disease brain and this is MSA brain. But clinically, it can be very hard in the first 3 to 5 years to tell them apart, but eventually they look very different.
Start.
You were talking about people in the same family having Parkinson's. My sister and I have it. We thought that was unusual, so we started investigating my father's side. He was an alcoholic, so he shook anyhow, but he had a lot of symptoms that went along with Parkinson's. My mother, my grandmother, definitely shook, and she acted like she had Parkinson's. So do I have my children, should they check and see if they have it?
It sounds like that many people in your family have Parkinson's, and that raises a concern that your family may have some of those genes that increase the risk of getting Parkinson. However, we think Parkinson's comes from the environment, and a lot of time different family members have Parkinson's because they have similar environment. You know, if the family is all living on a ranch in rural and drinking out of well water, and 2 or 3 people out of that family gets Parkinson's because they had similar exposure to well water drinking, to heavy metal, to insecticide, pesticides, and things like that. So often family members have Parkinson because of similar environment, not because of genes. However, it is concerning and it could mean that there are genes in your family that make you guys more at risk of Parkinson's, but more doesn't mean absolute. It's still under 10%. So there's a 90% chance that someone with your genes, you know, children, may not get Parkinson's, you know, because of healthier lifestyle, better living, different environment, and things like that.
Okay.
However, if you are interested in genetic testing for those risk genes, you can do it on your own. It doesn't have to be a test on your kids. You can do it on your own, and if you find something, then that means that you may have transmitted that to your children, and that may also increase the risk of Parkinson. And then they can think about their own genetic testing, but you could start from your own test from the 2 studies that I mentioned.
Okay, thank you.
I'm muting
The
again.
studies that you mentioned.
All right. I know you probably need to head out, Dr. Bhatti, but
Yeah.
thank you so much for all of this information. It was very informative, helpful. We really appreciate your time and help towards educating the community.
Thank you very much. Thanks for having me.
Thank
Bye,
you so
everyone.
much. Bye-bye.
Thanks for joining. And if anybody wants to review it, we did record it. It'll be on our website as well as our Facebook page. So thank you again to everybody for joining. And thanks for joining us, Dr. Bhatti. We really appreciate it.
Have a good day, everybody.
Bye.
Bye.
In the basement.